Brilliant. So welcome everyone. It's my great pleasure to welcome you to the Psycho-oncology Co-operative Research Group webinar on clinicians in research. So my name is Haryana Dhillon. I'm a behavioural scientist at the University of Sydney and PoCoG's the chair of PoCoG's Scientific Advisory Committee. And we're here this morning with three of our members who are all clinician researchers in different fields. And I might just take a minute to introduce each of them to you this morning briefly. So, and I'll do that in the order in which they're going to be speaking this morning during the webinar as well. So the first is Priscilla Gates, who is a consultant nurse specialist in haematology at the Olivia Newton-John Cancer Centre in Austin Hospitals, who is currently in the midst of her PhD, which I think is one of the topics that she is going to talk to you about. And then we have Malalasekera, who is a medical oncologist and researcher at the Survivorship Centre at Concord Hospital, and also working in phase 1 clinical trials at the Prince of Wales Hospital. And Lesley Stafford, who is a clinical psychologist at the Royal Melbourne Hospital, and Lesley is going to be talking about some of the work that she's been doing in breast cancer as well. So just a little bit of housekeeping before we go any further. So at the moment, we've brought you all in without, we're muted. What we'd suggest you do if you've got comments or questions that you'd like to make in the, use the chat function during the session. And we'll see how it goes and maybe open up the audio so that you'll be able to speak if you want to when we get to the panel discussion. I should let you know that this is being recorded, and the intention is that we will add this to our YouTube channel, so it will be here as a resource for people beyond just today's session as well. So once again, thank you for joining us. And I think it's important that we also acknowledge that we're meeting today on the traditional lands of the Australian Aboriginal and Torres Strait Islander peoples, and we have people around the country. I'm here with a number of other people on the Gadigal lands of the people of the Eora Nation, and I know that many of you are in different places. So I'd just like to acknowledge the custodianship that the elders and past and present and have held for this land over many millennia, and to take that with us as we go through this session today. So with all of that done, what I might do is invite Priscilla to speak to us, and we've had a number of people who are just joining us late. So Priscilla Gates is a clinical nurse consultant in haematology at the Olivia Newton-John Cancer and Wellness Centre and Austin Hospitals, and I'll hand over to you now, Priscilla.
Thank you very much, Harry, for the introduction, and thank you to Bonnie and Harry and PoCoG for inviting me to be part of this webinar today. I will share my screen because I just have a few as part of my introduction, just about my background and importantly, the PhD study that I'm currently undertaking. So I'm just sharing it now, hopefully. Can everyone see that okay?
Yeah, we can see that.
Sure, thank you. So once again, thanks for the introduction. My name is Priscilla and I am currently employed at the Olivia Newton-John Cancer Centre at Austin Health as an autologous bone marrow transplant nurse coordinator and also nurse lead of our haematology survivorship clinic, which I run my own nurse-led survivorship clinic for patients post-treatment for haematological malignancies. I have a long background in haematology nursing, and really through my current clinical practice in the haematology survivorship clinic has really driven my questions, decision-making, and really inspired and created opportunity for me to undertake my PhD study, which I'm just about to reach the 2-year mark. My PhD study is exploring cancer-related cognitive impairment in patients with aggressive lymphoma who are undergoing standard treatment with curative intent. And my PhD question, my exploration has really been driven by dealing with patients over 2 decades undergoing treatment for hematological malignancies, particularly patients attending our survivorship clinic who are quite negatively impacted by all degrees of cognitive impairment. So undertaking this study is a great opportunity to answer some of my clinical decisions, and you know, I really look forward to being able to disseminate the findings that we're going to discover through the 30 participants who are very kindly involved in our study. So just to give you a quick snapshot just of my study, it's not really about my study today, but just some of the decision making, the multidisciplinary team and the support that has gone into my study. So patients, the eligibility is really patients with newly diagnosed aggressive lymphoma. So they're consented right at diagnosis. And as many as you would know, patients with aggressive lymphoma, there's a real rapid turnover between diagnosis and starting treatment. So as a clinical researcher, you really need to be clinically embedded in the team to be able to approach these patients at this time of high stress where they've received a diagnosis of an aggressive, potentially life-threatening treatment. So once the participants are consented, they also need to undergo their baseline assessments. And this is really around the novelty of my study, is that as a group, we feel this is the first study of its kind, that we're able to do treatment naive baseline assessments in patients with aggressive lymphoma pre-treatment commencement. The assessments that we do at baseline is demographic assessment. We assess subjective self-reported cognitive function through 3 cognitive screens, which are all listed here, and also assessing fatigue and emotional distress. And they also undertake a battery of neuropsychological testing, which was based on the international guidelines from the International Cognition and Cancer Task Force. They do the Stroop, Color and Word, the trail making, the Hopkins, the Cower and the digit span. We also look at the association of inflammation with cognitive impairment, and they have a set of inflammatory markers measured as part of their standard of care bloods. And in participating patients, we also are doing neuroimaging at the 3 time points, being PET-CT, the brain, and MRI, the brain. So the participant has their baseline assessment, and to measure the burden of assessments during this time of high stress, I undertook a qualitative interview with the first 5 participants to assess if the burden was appropriate, which it was deemed to be so. The patient then commences their standard chemotherapy. Halfway through, they undergo the same set of assessments again, and then they complete their chemotherapy as per standard care. 6 to 8 weeks post again, we do the same assessments again. And then importantly, we're collecting qualitative data through a patient experience interview at the end. Our recruitment to the study has been better than expected. And also compliance with all study measures has been excellent. So through this experience interview, we are trying to better understand the motivation behind patients being so willing to participate in this study at diagnosis and a time of heightened stress, and also their expectations of their study and their motivation to stay engaged. So where this study is to date, we completed recruitment at the start of September. We recruited our 30 participants in a 9.5-month time frame. There were only 3 patients who declined participation. There was 2 young women in age below 30, and also an elderly gentleman who was an inpatient at the time, who was aged 82 and was too overwhelmed. I'm pleased to report that our protocol is being published in the BMJ Open and is in the final stages of printing and should be published within the next week or so. So to conclude, really to talk about my role as a clinical researcher, I've just put this little algorithm together to really talk about what I think, which is really important and have been the major wins for my PhD study. Firstly is to have the right people involved with your study. And if I reflect on my four supervisors, one of them being Haryana Dhillon, is really able to bring in the experts in this area and, you know, to be able to share their expertise and their support to enable me to grow as a clinical researcher and to grow my knowledge, learning from their expertise. In my study, I also have a panel of expert advisory panel, which is really bringing in the expertise around lymphoma. So I have our medical head of lymphoma and also neuroimaging experts and expert around the laboratory inflammatory markers. I'm very privileged that I've been able to maintain my role as a clinician. I still work 2 days a week as a clinician at the ONJ Centre. So this has enabled me to stay clinically embedded in the clinical service and work amongst the multidisciplinary team. So therefore, I'm highlighted to me of any new lymphoma patient who comes to our centre. I'm privy to attend the lymphoma MDMs, the clinical discussions in outpatients. So any new patient is highlighted to me. So this gives me direct access to patients, inpatient. We recruited about 8 inpatients onto our study. Some of our patients within diagnosis and starting treatment, it was a week or 2, but even a couple of our patients started treatment a day or 2 within diagnosis. I was able to have the right information about the right patient by the right people. So I always felt totally informed of any new eligible patient who is a part of our clinical service. And being a clinician and a hematology nurse consultant, I was able to always have the informed and right knowledge about what this treatment journey or trajectory was for the patient. And it also gave me the specific empathy and understanding that was required at this time point for these people at the time of diagnosis. So I was able to talk to them about the study in a very empathetic, knowledgeable manner and to create the right environment that the patient could trust me as part of their clinical team to engage with the study. And I think that's really reflected by only 3 people not wanting to engage with our study. And also enabled me to be very flexible within the clinical setting, that I was able to make myself available at any time point for these patients. And that really led to the compliance with the study measures to date, because I was always available to meet with them whilst they were in the hospital. If they were seeing, having their chemotherapy or their diagnostic workup or their imaging or seeing medical clinicians, I was able to be there at that time point. And that really was a major win amongst the COVID pandemic, particularly the impact on clinical settings in Melbourne, that I always had to be there when the participant was there, because we would not bring them in for a dedicated visit for our study. So that's the introduction to my study. I hope that's been helpful, and I'm willing to you know, participate in the rest of the webinar and ask any questions that you have. Thank you again.
Great, thank you very much, Priscilla. And can I just ask, does anyone have a burning question that they'd like to ask Priscilla? If you type it into the chat, we can look at it before we move on. Maybe not. So keep the questions coming. Do put them in as we go through, but we might move on now to get Ash to tell us about her experiences, which will be in a little bit of a contrast to Priscilla's, who is still going through the process of doing her PhD at the moment. And Priscilla, might get you just to mute yourself for now, if that's
Sure.
okay. Yep. So I'm really delighted to introduce, again, for the people who were not here when we started the webinar, Dr. Malalasekera, who is a medical oncologist working both in phase 1 clinical trials and in cancer survivorship. And Ash completed her PhD within the last 5 years, so she's kind of early career researcher status, and very interested to hear about her experiences.
Thank you, Harry, and thank you for the opportunity to speak today. It's a real privilege to participate in these conversations and to hear the other stories as well. And just hearing Priscilla sort of talk about her work and her passion sort of incited all the memories of why research. I want to sort of go through some of the points that Haryana sent through to discussion points and give a little bit of a background on the decisions I've made so far. So one of the questions came up about how clinical practice directs research. I am first and foremost a doctor, and I find that to be the most exhilarating part. Helps boil down perspective on a daily basis. And not only is it fulfilling to try and fix a problem, but it's also very sobering to I see what gaps are out there for our patients and their carers. We often get asked questions like, is there a cure for cancer? Is this going to cure my cancer? Is this going to control my cancer? And we thought, I mean, those amongst us here in this forum would have thought that, we'd have some keep getting asked means that there are recurring issues and recurring questions that have not been answered from our to our community. There are also evolving issues, and we all know about what's going on at the moment and how we're trying to shift our practice to those new changing boundaries, so to speak. I think it's very important in clinical practice to watch what works amongst our colleagues as well. And I'll talk a bit about my team, the teams that I work amongst shortly. But experience to see the breadth and depth of skill amongst our academic researcher colleagues, our mentors, and our allied health professionals. There's a diversity of strengths, and that is another wonderful thing to bring into research questions. Ultimately, also in clinical practice, we have to be able to answer our patients and carers' questions outcomes, and this builds a case to help give some hope and options to them, and attract attention and support for continuing our research. I integrate clinical practice and research simply through team communication, consistent communication, and hopefully not making the same mistake twice. And I'm very much relying strengths of our team members. I'm also quite conscious to see where everyone in the team wants to go and how we can all support them in that journey to be able to build a team spirit, so to speak. As I said, the benefits of combining both roles are mainly perspective, but it's also really wonderful to be able to come through a PhD and start working with more and more curiosity. Every day we are less judgmental and less fixed. So it's a wonderful thing to have an open mind. it's a constant opportunity to improve. It's a constant chance to hone a skill. And ultimately, we have a lot of work to do in providing equity of care. And so that's why I think research and drive to find better answers for why we're doing what we're doing, an even playing field, or an even field of options for patients, so that no one feels left out or disadvantaged. There are challenges in combining both roles, certainly, and I suppose the main thing, of course, and I'm sure everyone here understands, that time is, we are time poor. When you work part-time in 2 different locations at 2 different ends of the spectrum in terms of where patients are in their journey, it can be hard to manage and do a full job in where you are on the day. And I think this year, we have all taken on an extra sort of administrative burden. There's, I'm pretty sure, pathological email disorder, where I open my email and I'm just a bit frazzled, but you can't sort of ignore, all of these avenues of communication. So I think that's and sometimes, sometimes generosity doesn't pay the bills. We'll all, let's be frank, but it's just something to think about. And in this era, it's important to maintain a good social media platform to, raise the profile of what we're doing, and that can be hard if you're not good at it. So I found that to be a challenge, and ways to sort of promote research and promote the. I'll show you a couple of slides just to sort of, give you an idea of who I work with and what we do. So I'm working sort of, backwards to how Priscilla presented. I'll just start sharing. Can everyone see that?
That's great.
Yep, yeah. So one of them hasn't yet sent me consent to use an image, so I've had to cover a photo. But this is our multidisciplinary survivorship team of health professionals at Sydney Cancer Survivorship Centre at Concord. We are now about 7 years old. We have been seeing patients who have completed treatment, complete primary treatment for early stage cancers, and at our new clinicians including Cindy, our dietitian, Sue, our clinical psychologist, Kim, our CNC, Jane, our exercise physiologist, and Jeanette and myself, a medical oncologist or one of our registrars, and the surgical CNC. And there is a care plan that's developed for them to help direct their information and physical and other unmet needs, give them a surveillance plan, give them a plan for risks or worsening of current residual toxicities, and also identify and anticipate any gaps in supportive care. And we switched this year to Zoom, and there's your screenshot, very proudly taken by Cindy from our first clinic. And I also run a trial for patients who are experiencing cancer-related fatigue following treatment. And that we started, that's a feasibility trial of stress reduction and targeted physical activity. We started recruiting and started the trial face-to-face in February, and then a couple of things happened and we had to switch to virtual. So that was a very interesting and exciting experience to be able to continue a clinical trial for a vulnerable population of two essential elements, exercise and mindfulness. I think two things that the whole world probably needed during that time, with support in a safe way and with a little our clinical team. So that was a great sort of experience to come out the other end, and we completed that, and now we're just doing the last feasibility run in those patients, and hope to have the results by the end of this year. That is a PoCoG endorsed study, and it was a protocol that I developed at the PoCoG and Concord research concept development workshops. Final slide, why do I do what I do? So phase trials for patients with advanced cancer who have exhausted all conventional treatment options, but are still well and fit and are looking for treatment. And this is a card we received a couple of weeks ago from the carer of one of our patients. And this is what she wrote to our team. And that was the day that she realized that time, and he's since passed away, but it made all of our days when we got that card, in that, you know, research gives options and options mean hope. That's all. Thank you.
Fantastic. Thank you, Ash. That's really interesting. Very different spectrums in terms of the areas that you're working in at the moment. And so just a reminder to everyone to type your questions into the chat function if you have them, or comments or things that you want us to come back to in the panel discussion, and we'll make sure that we do that. So now I'm going to hand over to Dr. Lesley Stafford, who's a clinical psychologist at the Royal Melbourne and Women's Hospital. And Lesley is going to talk to us about her experience as a psychologist, clinician researcher. So over to you, Lesley. Thank you.
Thanks, Harry, and thanks for the opportunity to talk at this event today. So I think I'm a little bit further along in my career trajectory than the previous speakers. I was employed here at the Women's Hospital just over 13 years ago to develop a formal psycho-oncology research program and also a clinical psycho-oncology program. And at that stage in 2007, I was the first clinical psychologist ever employed at the Women's. So I think it sort of tells you a bit about the landscape of psycho-oncology in Australia, and you know, in such a premier hospital like the Women's Hospital. So I've been here in all of that time, and I'm very proud of our success. I also I've sort of thought a lot about the questions that Harry sent to me in the last few days, in terms of how do you integrate research and clinical work? What are the benefits and the challenges of combining these, and how does that feed into being part of a multidisciplinary team? I think that there is a certain credibility that you have from being a clinician when it comes to being part of a big multidisciplinary team for a grant proposal. Now, I mean, I say that with obviously the greatest respect for non-clinicians, but when you do work in the clinic and you have that everyday contact with patients, you also have everyday exposure to clinicians, and then you're top of mind when it comes to including you in a project for which they think you have clinical expertise. So that's one thing that's certainly an advantage. And I think Harry's asked me to talk about a couple of the projects that are PoCoG endorsed in breast cancer, and that's obviously the area of my speciality, being based in a women's hospital. One of those is quite a large study funded by the NBCF where we're looking at universal germline testing for women with breast cancer. So usually you would get germline testing if you came from a family that had a lot of risk in it, or because of the nature of your pathology. But the question here is, what happens when you take the first 150 women who come in through your door with breast cancer, and not necessarily any particularly suspicious pathology, and offer them germline and somatic testing? How does that change their treatment? In what ways? And is that acceptable to them? Is that acceptable to the clinicians? You know, and then from a psychological point of view, does that heighten patients' anxiety? Does that make them worry more about having a more serious cancer, having been offered a test that they may not otherwise have been offered? So I think this is an example of a research project where I might have been the go-to person to be included on that project, because this is the work that I'm doing every day in the clinic, and I'm based here. So there are very strong advantages to that. I think also that clinical practice informs my work in lots of different ways. Everything from the ideas that I have for research projects, you know, smaller sort of independent research projects, right through to the way in which I then interpret those findings. Very often in my clinical work, I'll realise that there are unanswered questions, or I have lots of anecdotal clinical evidence, but there actually isn't anything rigorous in the literature to back up those anecdotal and those clinical observations. So a good example of that would be, we probably see maybe 3 to 4 women a year who have breast cancer in the context of pregnancy. Obviously a very difficult experience, over and above the challenges of pregnancy, over and above the challenges of cancer. Very tricky both for the patient's family, and also for our team. There's just an extra layer of vulnerability around these women, and they don't seem to fit well in either the maternity or the obstetric world, or the oncology world. So, you know, 3 to 4 patients a year, it's not a huge number, but it kind of sparked a question about what do we know about the mental health and supportive care needs of these women? And I was able to get a small pot of money to go ahead and examine this, and recruit a group of women, their partners, and health professionals, and do some qualitative work around that. We're busy analysing those findings, but when we have them, that will then feed into, very meaningfully, a more evidence-based model of care. So we're kind of, you know, I'm not saying we're doing a bad job, I think we're doing a great job, but we'll have an evidence base from which to work. So I think that's another advantage. And I think Ash talked about this. One of the sort of downsides or less advantaged part of having both roles is that when you have a clinical role, patients come first, and patients always come first. And it's very rare, depending on the way your job is set up, I guess, to have protected, demarcated time that is just for research, and you are not to be paged and you're not to be contacted during that time because you're thinking and writing. So that sort of doesn't exist. So like many full-time academics, you do a lot of your research work, your academic work, after hours. So that's not any different to full-time academics, but it is tricky. You don't have that full scope of flexibility, and that extends into other things then as well. So if I wanted to go to a conference, I have to think, well, who will see my patients while I'm away? That's always going to be the question that's asked. There isn't that kind of flexibility. So and I'm asked this fairly often about a dual career. My suggestion often is, if you are interested in being a clinician and a researcher, try and have your academic role through a university where you have more capacity for conference leave, you have more understanding around the need to meet other people. When you're employed like I am through a public hospital, I think I get, say, 5 days of professional development leave a year. And I have to do my clinical professional development in that time as well. So, you know, that's a very practical thing that really, if you think about, if you're a full-time researcher, how much time you spend at meetings, engaging with others. The other part of the clinical load is just less time to work on grants. So I can't meaningfully compete for, not just because of that, but I can't meaningfully compete with a full-time academic. But on the plus side, because I have clinical skills and a clinical role, I'm also not living grant to grant. So when I look at my colleagues and friends, many of whom are absolutely brilliant at what they do and really, you know, the top minds in this country, and I see that they are constantly under stress about, if the fellowship is not renewed, if I don't get this grant, what am I going to do? It's too late to requalify, to do something else. Where will I work? Where will I go? That's something I don't have to worry about because I have the clinical skills. And so that is that sort of kind of balance that I juggle all the time. One of the other questions Harry sent through was, why do you do what you do? And again, I'd echo, I think, what Ash said. I'm a curious bird by nature. And I believe in public service. I believe that everyone should get high quality care regardless of their circumstances, and that's what public service offers. And by combining the two things that I combine, I'm able to ask and answer questions in a relational way and solve problems in both spheres of the work that I do. And that's very satisfying, very privileged work. And, I feel very lucky to have the opportunity to do that. I think I might be out of time, so maybe we'll leave the rest for questions.
Fantastic. Thank you all so much. That was really lovely to hear all three of your perspectives and the marvel of the experience that you have of, as well as the stresses of combining the dual roles that you're all in. So just a reminder, we've got the chat function is open, and Bonnie, Jo and I are watching that, so we can ask any questions that you have, or feel free to unmute yourself or indicate to me by, clicking on the reactions for either a thumbs up or something, and I can come to you to get you to talk about your question. But in the absence of any questions yet, I think one of the themes that really struck me about the presentations and the experience that all of you described was the importance of your teams, both your research teams and your clinical teams. And I just wonder if you might want to, if you can expand on that a little bit more and kind of, describe some of the experiences of, how, when you're making your decisions about whether to start going, whether to take up a particular research project, how those interactions occurred and how that, the clinical relationships in those teams kind of shape the research questions that you're asking. Maybe Priscilla, we can kind of start with you, because I know yours, I know a little bit more about some of the work that you've done as well, because I've been involved in it, but we were very concerned about the feasibility of your study, or, the kind of question that you were asking at the beginning. So yeah, don't forget to unmute.
Sure. Yeah, thank you for the question, Harry. I think, as I sort of talked about before, I'm so clinically embedded within hematology oncology team, which I've built over decades. But with my research question and doing the feasibility around these subjective and objective measures at these different time points, particularly when we start looking that we were doing the neuroimaging in these patients. So there was so much, for myself being a PhD student, there was so much relationship building around that question, if we could even feasibly obtain the neuroimaging. So I think my research question was so well supported within the hematology oncology team, but it was building that respect and understanding amongst other multimodality clinicians, in particular the neuroimaging faculty at the Austin. So I had to then, as a nurse, you know, go and meet with, for instance, the director, professor of molecular imaging at Austin Health. I was unknown to him. He was unknown to me. And it was really around building those professional relationships around him, firstly respecting my research question, respecting my knowledge, which I certainly, as a hematology nurse consultant, had to build a baseline knowledge about neuroimaging. So, you know, it was quite complex. It was challenging. It put me out of my comfort zone. At times it was overwhelming. It was also not only building the relationship that they had buy-in. Now he is a co-author on the paper and part of the advisory panel, but, you know, was, you know, also understanding, you know, the feasibility around it, you know, getting the buy-in from the patients to have this extra neuroimaging, which is not part of standard care. Understanding also the analysis behind the neuroimaging, getting, you know, also the buy-in by, you know, the further imaging team around, you know, what results they would be giving us as part of the MRI and the PET-CT scanner. So I suppose in summary, it was really going out of my comfort zone of my own clinical team, where I feel very comfortable, respected as a clinician, like Ash and Lesley, you know, talked about, and gaining that respect in a much wider clinical field, you know, which did take time. I'm still working on it, you know, but to think that they're now co-authors in the paper and all the imaging has been completed, and patients have been very compliant with it. So.
Okay, fantastic. Thanks, Priscilla. Lesley or Ash, would either of you like to add anything about, you know, your teams and how they function?
Sure. I think there is a medical research, the medical world is very hierarchical, and allied health, supportive care doesn't often feature very high in that hierarchy. So I think there is a real need to, so that's not the same as you know, researchers not appreciating the importance of supportive care. Certainly there's a lot of talking the talk, but when it comes to actually walking the walk, what you want is research that takes into account more than just a quality of life questionnaire tacked on to a trial and said, okay, well, that covers the you know, the patient reported outcome measures, that covers the supportive care, you know, kind of all the soft stuff done. That's not what we want. What you want is to be able to advocate for, in my case, for the experience of my patients, and to know your stuff and to believe in what you've got and to believe in the clinical importance of including those things. So there's also no point in including a quality of life measure for the sake of including it. What are you going to do with that information? How will it be clinically relevant? How will it change? How will it change care? So I think in these multidisciplinary teams, and I'm fortunate here, I have a real seat at the table in the breast oncology service, and that's partially, I think, because of my clinical role. It's partially because of my research track, but my commitment, but also my passion, and I'm very persistent. I say the same things over and over and over again. And look, it's taken a while, but we're now at the point where patient-reported outcome measures are proactively built in rather than added as an afterthought. Mm-hmm. So it takes time working with those teams to, you know, to advocate for your discipline, to advocate for that. But eventually you do get there. You need an ally though. You need at least one ally. So that's in response to a question from Joe. You know, what advice do you have for non-clinical researchers on approaching a clinical team? Be strategic. You need one ally who will have your back, and usually that gives you a footing.
Mm-hmm. Fantastic, thank you. So we might move on. Ash, I might ask you if you want to give a perspective on Joe's question as well, about what advice that you might have to, as clinician researchers, to non-clinical people about how they can approach clinical teams effectively and build those relationships.
Yeah, thank you. I feel sorry that that question had to be asked. It feels like, you know, we're biting heads off, and that shouldn't happen. Clinicians must be open to change. It's hard, but we have to be able to respond to change and to improve practice, because things aren't perfect. And any advances that have been made are because somebody stopped to listen. So believe in what you're doing, and sell yourself or the benefits of what you're doing. We are not, you know, traditionally taught about cost-effective healthcare. We're not taught about the extremely positive outcomes that come from nurse-led initiatives. And, you know, but if you educate us on that and why, you know, you're doing what you're doing, those are and those overlooked aspects that we're not aware of, that'll sort of, you know, add to your argument on why we have to meet in the middle. And, you know, your time, you've got different time pressures to us, but there's still time pressures. So our time is not more precious than yours. Of course, yes, if a patient's unwell, and, you know, that takes precedence, but we wouldn't be, you know, checking emails or answering phones if somebody was unwell in front of us. So, so believe in what you're doing, and lay out the case on the lack of evidence that is out there, and how your initiative could try and meet those gaps. And what are some of the do's and don'ts? I guess, I mean, whenever I'm approached, it's in such a, you know, polite and helpful way, and I can't sort of think of anything differently. I'm not sure, yeah.
Yeah, okay. I might just ask a kind of a related question, which is really, I guess, about how, because Lesley, you mentioned that you had a seat at the table and you had the respect clinically, and Priscilla, you've talked about that as well, as being, you know, non-medical doctors who are as part of the clinical team in an allied health role. As non-clinicians, how do you think that's an important aspect that researchers kind of need to build, that you kind of, do you need to demonstrate that you have a good understanding of the clinical scenario?
Yeah, look, I think so. I think without that understanding, well, without showing an adequate understanding, I think quite predictably your credibility would be questioned. So, like all research, the question is, so what? Right? So you would want to be able to say that if we can do this and we can show this, then our patients will benefit in X, Y, Z ways. And that's ultimately why we all do this work, because we want our patients to benefit. So if you can show an adequate clinical grasp of what those actual issues are, how this will improve morbidity, whether that's psychological or physical, then you've got a much better chance than sort of coming with really interesting questions that have at most a theoretical application, and are considered luxurious research because they can't be applied. Yeah.
Okay, so that applied research question being really critically important, or knowing where you're going with it, maybe. Yeah. Did you want to add something, Priscilla?
Oh, Harry, I was just going to say, and I think that clinical knowledge, not only does it get you the respect of the clinicians and the clinical team, but it also gets your foot in the door. You know, if I go back to my experience with my study, having that clinical knowledge, that clinical respect, that clinical buy-in, which was what enabled me to, you know, to be able to access potential participants for the study, you know, at such a rapid turnover time point between diagnosis and treatment. So I think if you didn't have that clinical knowledge, clinical respect, clinical buy-in, and that you're amongst the clinical setting, some clinical research may just not be feasible because of the fast pace of what that clinical setting is working amongst. So in my situation with my study, being a clinician was certainly probably, you know, the major reason for the success to date.
Fantastic.
Harry, I just want to be a little bit careful that people don't go away from here thinking that, you know, you need to be clinically trained to do well. I think if we look around PoCoG, the superstars in research are actually not your clinician researchers. They are your your academic researchers. And I think we need to be very clear about that this is about a kind of a consideration of pros and cons and some reflections on that. But certainly, and I wouldn't want anyone to go away from here thinking if you're not clinically trained, you've got nothing to offer, because there's absolutely no basis for that, and it would be, quite frankly, very untrue.
Yeah. I think that's a fantastic point to make, Lesley. So thanks for raising that. And I guess what I was thinking about while you were talking about this is, because you are all clinicians, getting, you know, developing some clinical knowledge and an understanding of cancer and its context is really what you have done in your clinical training in your day-to-day working lives. So as someone who is not clinical, one of the things that I found really useful, particularly when I was in the early years when I was working on research, was actually to sit in on a clinically led journal club. And so if you can kind of find one of those that in a hospital that you are affiliated with or someone would welcome you to, that's actually a really good way of certainly, you know, meeting people and coming to an understanding, I think, about how practices changed and how people process information and ask questions in that setting. And I just found that a really good way of developing my understanding of different cancers and the issues that are, you know, that are associated with each of them. So I think that's really important. So Lorna had asked a question about difficulties and tensions in communicating. She kind of feels that's answered, but I just wanted to ask, you know, if any of you have a situation where you have found it particularly challenging in communicating with you know, another group of clinicians or researchers, and how you kind of went about overcoming that. You may not have any because you're all fantastic communicators, but...
Harry, I can only once again reflect on, you know, which Lesley touched on, being a nurse and having to get my foot in the door with the medical hierarchy, particularly in the neuroimaging space that, you know, I have no knowledge and unknown. I think my main lesson learned from that was getting that key introduction. So not coming as a new person, as a cold face to that meeting, but, you know, I was introduced from our, you know, medical director of haematology. So that sort of gave me a key foot in the door and an introduction of whom I was, because I think if I had have tried to set up that introduction myself, it may have been more difficult.
Okay, fantastic. I guess in the other question that I was going to ask all of the panelists as well is that you all touched on the idea of curiosity, and I'd be interested to hear a little bit more from you about where the curiosity comes from, and is that something that helps you sustain your clinical roles, which are obviously at times quite physically and emotionally draining. Is the curiosity something that helps to manage that potential burnout?
I'll step in there. Yes, on your last point, Harry, absolutely. I think it's a very healthy feeling to be curious. It's relaxing, and it reminds you to keep an open mind. And that came from being a researcher. I think the more you learn, the less you realize you know. And that comes in from asking questions, you know, the basic PoCoG questions, learning about statistics, learning about biostatistics, and how there are all these different variables to account for. And when you're putting a recommendation to a patient, how to explain the strength and the reliability of those findings. And that's all coming down to having an awareness because you are curious.
Mm-hmm.
And it's also because you're probably becoming less judgmental in a way with talking amongst each other, and realizing that different people, as Lorna's question sort of insinuates, that different people have different perspectives on what's important. So maybe that curiosity can make, you know, help you stop and go, why are they fixated on this particular point? Why are they thinking this is important? What's the evidence behind it? Is it anecdotal? Is it, you know, is it a sort of a valid, you know, it must, then how can I sort of validate that perspective? So it helps. I think I might have mentioned it, but it really helps to have mentors. You know, you're one of my mentors, you're one of my PhD supervisors, but having a mentor who you can look up to and who you realize is still curious, and after a breadth of experience and you know, a lifetime of collaborations, and they're still curious, it's you know, it's quite encouraging. It's very encouraging. Yeah, so yeah, I think you have to stay positive and surround yourself by, you know, good people, happy people. Stay true to yourself, and I think you'll find the difficulties and the tension will just eventually pass. And you know, it's a great experience.
Fantastic. And Lesley or Priscilla, did you want to add anything?
Look, I think that if you have the opportunity to funnel some of your curiosity into research, that's actually a terrific buffer against the emotional drain and demand of ongoing daily clinical work. So I see research and academic work is stressful in a different way, but it's not emotionally taxing. And it doesn't, not in the same way, it doesn't require my presence in the same way that that clinical contact does. And so I actually think that it's a really strong protective factor against burnout in lots of ways. So yes, if you have that opportunity to funnel some of that curiosity elsewhere, and not just in in-person relational work, yeah, it's really helpful.
Fantastic. And certainly that's my anecdotal observation of people I work with, that I think that they do gain a lot in terms of balancing their clinical, the weight of their clinical load against, you know, with research, and that brings a different energy to what they do. One of the things I was going to go on and ask about, just a reminder again, please do ask your questions in the chat, because I'm watching that quite closely. But I'm interested to think a little bit more about the institutional issues that may come into play. So, you know, Lesley, you talked to you know, earlier about the kind of the difference that it makes in terms of having a university appointment or a university position versus just being solely employed through a hospital. So I was just wondering if I could get you, each of you, to reflect a little bit on how that experience, you know, is, or what do you think needs to change systemically in hospitals or universities to make that an easier process?
So I'll go first. I think that I can't actually see this actually happening in my working lifetime.
Mm-hmm.
Hospitals are cash strapped. Research is not as important as clinical care in, you know, when you think about it in a very blunt way. Yeah, unless you are actually employed in a way where you're employed in the hospital but through the university, and that happens where people have a formal joint appointment. That's one way of doing it, but my experience is hospitals are quite reluctant to do that, because I don't know what it's like in other parts of the country, but in Victoria, you know, superannuation for a hospital employee is 9%, but for a university employee, it's, I don't know, 17%. So it's more expensive to employ someone through at the university. So I can't see that happening anytime soon in our sector. And if I reflect on my own experience, if I had my time over, maybe I would have negotiated differently. I've got lots of advice on how to negotiate, but potentially don't negotiate as well in my own space. And now again, I'm very cognizant of the fact that universities are in a very difficult position. So, you know, there's not likely to be a surplus of university positions going along, and many of us, I think, are just quite grateful to have stable employment. And won't be agitating for too much change anytime soon.
Mm-hmm. Fantastic, and I think I agree with you. They're challenging structural issues, but I really like the point that you're making about wanting to, you know, needing to know what it is that you don't know, and to think about what you would like your position to be like, so that you know, sometimes you can ask those questions more. You know, proactively as you're going in for trying to set up different positions and roles.
And one model of doing that, Harry, is to have a uni appointment and have a private practice.
Mm-hmm. Mm-hmm.
You know, there's a real shortage of clinicians in psycho-oncology in the community who feel confident and are interested in providing care for this population. So there's no shortage of work in the community. So that's one way of being able to try and fill both of those needs. Again, though, there are downsides to that. Private practice is isolating and lonely for lots of people, and you don't have all the, you know, wonderful benefits of multidisciplinary teams and the vibrancy of a hospital and their capacity to be learning new things all the time that you do. But, you know, swings and merry-go-rounds.
Excellent. And so, Ash or Priscilla, did you want to make any other comments about the systemic issues?
For that answer, because I'm sitting and listening, I can't, I don't know. I don't have a university appointment, and I'm in a mix of, you know, public practice and a not-for. That helps, you know, give a bit of perspective, but I don't have the answers on how to, but that's why I'm listening to them.
Fair enough. Fair enough. Okay. how are we going? So I just want to check back with all of the participants to see if there are questions that you wanted to ask at the moment. If you do, please unmute or type them in. I'm thinking that we may have kept our panelists talking for long enough at the moment. And I guess this is really an opportunity just to check in one last time to see if you have questions. Jo, did you want to say something?
Just excuse me. Sorry. I just actually wanted to pick up on a few things that the panelists have said, and it's kind of like a bit of an advertisement, a bit of a plug. So as a clinician researcher, leading a major program of work may not be possible. But the clinical relevance that clinician researchers bring to research questions and to programs of work is vitally important. And so I don't want people to go away today thinking, well, as a clinician, it's just all too hard and I don't know how I'm going to be able to lead a program of work or participate in a program of work. But I think that all of the panelists really have started with a gem of an idea for a research project and started small and then built teams that can facilitate the research. And then, so it's an iterative process and it is about teams and it is about, you know, you don't have to have the big idea to be a researcher. It can be something really quite small, something nuanced that's going to potentially influence clinical care. And so everyone doesn't need to go for NH and MRC grant, you know, clinical trial grants. There are lots and lots of opportunities. And, you know, part of our role at PoCoG is to support particularly clinician researchers with curiosity and questions to operationalize that in a feasible way so it does actually fit with their practice and build teams around great ideas. So that's kind of my plug.
Plug for PoCoG, which I think, you know, it is really important because we do have one of the most unique organisations in the world in the form of PoCoG. So there are cooperative trials groups all around the world, but we were the first that really focused on psycho-oncology and supportive care in that way. So I think, you know, this cohort of people who are our peers and our members are, you know, incredibly important and incredibly capable and supportive of, you know, asking really relevant clinical questions and have those networks into clinical teams in order to do that. And, you know, just one of the main drivers for setting up PoCoG was really the recognition that we needed to develop those bigger studies, national studies that could actually change systems and practice, which wasn't happening with the kind of university-based small single institution studies. So I think that's something that that we can all do. And, you know, as a consequence of that, we have a network of people all around the country who, you know, I personally would consider now not just colleagues, but many of them very close friends as well, because we share the similar values and interests, and that curiosity and drive to kind of improve the patient outcome and experience is really very highly valued and shared amongst our community. So I guess on that note, just one last check-in if there are questions that people have.
Harry, I wanted to sort of just a small idea. As an answer to one of the questions about advice for non-clinical researchers, and on Jo and your point, the concept development workshops are wonderful forums to meet clinicians away from, you know, Harry, sort of, you know, day-to-day work, and, you know, build networks and collaborations. So I do encourage, you know, non-clinical research to come to those and use those as, you know, ways to approach and build, you know, relationships for the future. I you know, I attended a few because we heard about them, and we heard about them from colleagues and from, and we got protected time to, you know, attend those, and they were just wonderful days packed with a wealth of information. And so I just wanted to sort of say that those should, I hope those carry on, and, you know, those are, that's one answer, potential answer for that question.
Great. No, thanks for raising that, Ash, because I think the concept development workshops are absolutely kind of core to the part of the work that PoCoG does. So, you know, there are some where we are absolutely calling for people to submit their ideas and their concepts, and really working quite closely with people in small groups or in large groups to really try and finesse those questions and make them the best that they can be. And we also have areas that we know are gaps, you know, in knowledge, and trying to make sure that there are some clinical questions that need to be addressed there, and really trying to make sure that we're bringing together the expertise from around the country that can feed into that and help us to potentially develop not just maybe one idea, but programs of work as well. So I think they're all incredibly important opportunities to really meet people who are clinically expert, but also have expertise in research that you may not know about or be aware of as well. So really hugely important. Okay, so we've been going now for just over an hour. So I think we might draw it to a close. I think it's been a really fascinating reflection on the role of clinician researchers and what it's like to be working in this area. I would like to say a very big thank you to Lesley, Priscilla and Ash for giving up your time and sharing so openly about your experiences. We really appreciate it, because I think it's a really useful and insightful you know, experience that we will have now for people to come back to as a reference point as well. And I think that I would just wanted to say that there are also some other PoCoG webinars that are coming up in the next few weeks, so look out for those and register if you're interested. And a reminder that we have all of the webinars that we've run to date over the last 6 months or so stored on our YouTube channel. So look for PoCoG on YouTube, and you'll find those things there as a resource for anyone that's interested in some of the different topics that we're dealing with. And a particular thank you to Bonnie for the fantastic support in setting all of this up and making the registration and running of the program as simple and straightforward as it has been. And also, again, a thank you to Jo Shaw, who's the Executive Director of PoCoG, for really supporting these ideas and allowing people to kind of take PoCoG in the directions and talk about the things that are of interesting to our membership. So thank you very much, everyone. And we'll say goodbye now. Thank you.
Thank you. Thanks, Harry.
Bye.
Do you want us to go?